Hey everyone, welcome to our today's session. I'm Dr. Mahin Ashraf from Bangladesh, and if you are new to our program, then we run this program in every week, every Friday for last few months. Recently, due to some issues, I couldn't continue for around a month. I think this is the first session for the May. But hopefully we will continue on our next future days. So thank you for joining us today. And many of you are connected here from many different groups because we have shared this content to somewhere other than this page. So if you have any question, you can just put down on the live section because I'm just watching the live also, like you. And let's begin with the 5 ultrasound cases that we want to discuss with you today. So if you have missed our previous sessions, we have already uploaded all those sessions in our YouTube channel. Recently, Facebook has changed its policy and they delete the live session after, I think, a month. So our previous sessions have been deleted. We can re-upload it on our Facebook page, but it's already present in our YouTube channel. So today's session will also be uploaded in our YouTube channel tomorrow. So you can just go and grab it there also. So you can just check our imaging study YouTube channel if you haven't already. We have got, I think, around 480 plus videos related to ultrasound. And fortunately, we have got 65K plus subscribers. We're very thankful to all our subscribers. And yeah, I hope to see you on our YouTube channel also. So let's start with our today's first case. And this will be a 29-year-old male patient who came with left inguinal and popliteal region pain and swelling also. So let's see what we have got on ultrasound. So here you can see the left inguinal region with high frequency ultrasound. Now you can see there are some large lymph nodes over there. You can see this large lymph node. This is important because I will show you the follow-up scan of this patient. So this large lymph node located in the left inguinal region is showing an enlargement, and also you can see this echogenic fat inside the lymph node is well maintained. So this is nothing but a left inguinal lymphadenopathy, which is not very uncommon case, obviously. So we need to put some Doppler, and on Doppler you can see very good amount of vascularity located within. And if you look the surrounding area, you can see the surrounding echogenic thickening of the fat. So this thickened fat layer also indicates that the patient is having an inflammatory condition. So the enlargement of lymph node with surrounding inflammatory conditions suggests us to look for the lymphadenitis. But we need to check the hilar vascularity. We need to check the peak systolic velocity, a resistive index, whatever. So let's put some pulse wave Doppler. So we put the pulse wave Doppler to the hilar artery of this large lymph node. And you can see multiple waves here. So it's too many artifacts. Ignore that. So the main vascular flow that suggests that the resistive index is 0.55. Whenever you see the hilar artery showing the resistive index less than 0.7, it goes in favor of the inflammatory condition. Usually the 0.7 to 0.8 is the cut mark for the lymphoma, and more than 0.8 is usually for the metastasis, though there are so many controversies, but it's quite common. So as it is less than 0.7 and it is common in our practice, we go for the inflammatory state here. Now, if you ask me, is it due to the tuberculosis or is the bacterial or whatever, I can't say it with the Doppler. I can say that this is inflammatory, but if you want to know further, you just go for the histopathological examination by FNAC or core biopsy, whatever. So we go for the inflammatory state here, and we'll say that this is a case of lymphadenitis involving the inguinal lymph nodes. Okay, so let's look at the popliteal fossa. Patient complained about the popliteal fossa pain also. And it's not common to see the popliteal lymph nodes. So this patient came with the enlarged popliteal lymph nodes. They are not enlarged, they are actually prominent because the short axis diameter is less than 1 centimeter. So we follow, it may vary from center to center. We follow the short axis diameter of more than 1 centimeter as the cut mark for the enlarged lymph node in maximum areas other than the mesenteric lymph nodes, where we follow the 5 millimeter of short axis value as the highest limit. So this one is the prominent painful lymph node. You can see the vascularity, not very high. So, okay, so we go send the report. The clinician gave the treatment with some antibiotics and so many things. So it was a case from the 1st May. Okay. Suddenly the patient came to me yesterday. So it was 29th May. So after 4 weeks, actually, the patient came to me. And after this long duration, about a month later, the popliteal fossa pain got resolved, so ignore that. But the left inguinal pain still persists, and the swelling, it looks more swelled up, and on palpation, it's quite soft now. So we are afraid that it may have turned into an abscess. So now the situation is not looking quite good, so we want to evaluate again. So now here's the picture. This is the picture from yesterday's. So it's a very fresh case. Now you can see, you have seen the large lymph node there, this one. Now I just put probe over that area, and now this is the condition of that lymph node. You see, you can't demarcate any lymph node here. Rather, you can see a very big irregular heterogeneous area, and you can see internal content, low level echoes. They're moving on compression. Patient is also complaining about pain in slight pressure. So it has turned into an abscess right now. You can see surrounding fat tissue irregularity, skin thickening, and the subcutaneous edema over there. These are actually some other lymph nodes. You can also see here some hypoechoic lymph nodes, and you can see there is no echogenic hilar fat. So they were present on previous scan a month ago, but right now you can see nothing. So this is already turned into an abscess. Let's see on many different views. So here you can see this abscess over the left inguinal area and surrounding fat thickening. So my intention is to give an idea about the cause of this thing. Like if the patient comes to you at this situation, you may end it as an abscess. But what is the origin of this abscess? Like how it became an abscess. So the cause is actually the lymphadenitis, and it turned into an abscess right now. So whenever you see an abscess at the location of typical lymph nodes, you should think about the lymphatic origin. Usually the lymphatic origin abscess, they have a shape like an oval shape or a shape like a lymph node. And they're in early stage, they're actually a localized abscess. So it's located at the inguinal region over the inguinal canal area. So this is quite common to be a lymphatic origin. So lymph node origin. So this is a abscess which is originated from an inflamed lymph node. We have changed the preset to the musculoskeletal one because this one is quite good to see the detail. And now you can see the internal low level echoes. They are moving on slight pressure. So these are nothing but pus, liquid pus. So it's like my hand is craving to stab on this abscess because we need to drain this thing. Okay. Oh, one thing. You see this structure over there? This one should be a blood vessel. Now, this is a little bit an alarming sign like, oh, I have found an abscess. Now I will stab on it. So you can injure this vessel. So on your report, you should comment on the encasement of this vessel by this abscess. So otherwise, the clinician may puncture this one also. So we'll see that. So let's put some Doppler. Now on Doppler, you can see surrounding soft tissue high vascularity. That is obvious for an abscess. And you can see there is a prominent vessel over here. This should be the inferior epigastric vessel, which is located at this point where I have just put the probe. So you should be careful about that, and you should note that on your report. So here you can see we have put some Doppler again, and now you can see this vessel is very prominent. You can see some lymph nodes over here, and this one is the abscess. Is it of tubercular origin? In our country, tuberculosis is much common for the lymph nodes, but you need to evaluate it further with the histopath or something like that. So this was the case, that is the lymphadenitis turned into an abscess on the left inguinal region. So you can see it's a large abscess. So with my linear transducer, it's quite difficult to show you in a single view. So I just joined two images on my dual screen mode. So it's not too much accurate, but it's quite good. So it's easy to measure the abscess. So you see it's quite deeper. On real time, we saw that the moving particles are seen up to this area. Not the accurate measurement because it's quite irregular, but overall it can give you an idea. So these are the enlarged lymph nodes, which are also present nearby, slightly deeper. And this was the vessel. So we check the vessel. You see, this is the vessel. And we check the surrounding vascularity. This is the vascularity of the deepest lymph node. It's still less than 0.7, which also goes for the inflammatory state. And yeah, this one is the vessel. So we just rotated the transducer. You can see this vessel is originated from the iliac vessel. And this is nothing but the inferior epigastric vessel, which is used to differentiate between the direct and indirect hernia. So it's quite prominent here, definitely due to the surrounding inflammatory state or something like that. So this was a case of left inguinal abscess and as well as the lymphadenitis, which was the cause of formation of this abscess. Okay. So anyway, fresh case. Let's jump into the case number 2. Before that, I want to request you to just make a comment about your location from where you are joining. If you're from my own country, Bangladesh, just make a comment that about your district or whatever you like. And if you are from any part of the world, you can just write down your city name or the country name. It's fun to see many people connected from far away from us. So together we can actually build a very good educational system and share our knowledge so that we can improve the patient's service, obviously. So let's jump into the case number 2. So this is a 9-month. Okay. So 9-month-old a boy who came with occasional seizure. He was sent for some brain ultrasound. You see the 9-month. So 9-month is not actually a good time to do the brain ultrasound because the fontanelles, they get smaller. So it's a little bit difficult to scan. If you don't have the sector transducer, you will face more difficult situations like me. So I don't have the sector transducer. I don't know why the machine seller is not giving me the transducer. So if you're from my machine selling company, then you just should rethink about that, because this case may look much better if I had a sector transducer. Okay, so anyway, let's jump into the case with my boring curvilinear transducer. So yeah, you can see this is the long section or the sagittal section of the brain, neonatal, not neonatal, this is the pediatric brain because 9 months old. And now you can see it looks quite good. I think it looks quite normal because all the sulci looks quite good. You can see the corpus callosum here. That looks quite nice. You can see the third ventricular region shows the choroid plexus here. This is the cerebellum. Enter to cerebellum, you can see the fourth ventricle. This is the third ventricular region. This is the cavum septum, uh, whatever you say. And this is the midbrain pons medullary region, brainstem region. So overall, the brain looks quite normal. I have no complaint about that. So I was a little bit happy, and I think it should be normal. But if it was normal, I won't be showing you. So just look at this image. This is the coronal section and the sagittal section of the brain with the curvilinear transducer. So whenever the patient comes to me for a brain ultrasound, I always try to use all the transducers I have, like the linear, curvilinear, and if I have the sector or phased array, whatever you say. So I want to use them also. So if you use multiple transducer, you won't miss the tiny findings in case of the neonatal brain, because neonatal brain is a very sophisticated area where uh, you should understand that you are doing the brain ultrasound and your competitor is the brain MRI. So we check the brain detail of brain with MRI. So when you are competing with the MRI, so you should be very careful. So you need to use multiple transducers to make the proper diagnosis. That's my recommendation. Anyway, so let's jump into this one. We have changed to the linear transducer. So now you can see a very good view. I'm using the Antiofontanale. The view is very good. You can see the corpus callosum now. It looks quite excellent. We have put the Doppler. You can see the anterocerebral artery, and this is the callosal, precallosal branches. So everything looks quite good. So why did they send the patient to me? Okay, let's see on real time now. You see, this is the thalamoganglionic region. So you see the thalamostrate vessels here, which are very prominent, and walls are echogenic. So I want to ignore that because it's 9 month old, but I couldn't ignore one finding. You see the cystic area over here, it is the left chordothalamic groove. So you see this one, it's located within the ventricle actually. So if you put the transducer just rotate it to the coronal section, and just I need to move the transducer a little here. You can see this one. This is located at the chordothalamic groove. So just go a little backward. Now you see this is the chordothalamic groove. This is the thalamus, this is the caudate nucleus. This triangular area is the chordothalamic groove, and you are seeing a cystic area at this part. The wall is a little bit of echogenic. Okay, so nothing within the ventricle. The ventricle looks quite clear without choroid plexus. There is nothing inside that. So this cystic area, what can it be? So let's see on another view. So here you can see I'm just checking the ventricle because I need to check the choroid plexus. You can see slight irregularity over the choroid plexus. Let me freeze the image. It will be clear for you. So just make it a little bit slow. You see it's slightly irregular over here. That may be a finding to ignore, but we have found an important finding at the chordothalamic groove. I can't ignore this cystic area actually. So this cystic area at the chordothalamic groove having a thick echogenic wall is nothing but the resolving hematoma. So whenever you see a cystic area at the chordothalamic groove, not within the choroid plexus, at the chordothalamic groove with a thickened echogenic wall, it's the resolving hematoma. It's very common in neonates, but it's quite uncommon in 9 months old baby. So I don't know the reason for this situation, but this is the resolving hematoma at the left chordothalamic groove. Obviously, a hematoma of birth won't persist up to 9 months. So this is I think some events have gone through during this situation, during this time. I don't know, but this is a resolving hematoma. Okay, so this was a case of resolving hematoma in the left chordothalamic groove, which is an unusual finding at 9 months old boy. Okay, case number 3. So this is a 60-year-old female patient who came with left knee swelling over the patella. You asked me about the musculoskeletal cases. I'm not very good for the musculoskeletal ultrasound, but I get some cases. So um, let's just share them. So I'm confused. Is this one is a musculoskeletal case? The patient was sent for a musculoskeletal scan, but let's see. So there was a swelling over the patella, and make sure the patient is 60 years old female. So they were thinking about some effusion. There was no history of trauma, but it's a little bit confusing. So that's sent for an ultrasound evaluation. Let's see what we have got on ultrasound. So this echogenic structure is the patella. So I'm using a linear transducer over the patella swelling. So you see this structure over here. This is the lesion, and you see multiple septations. You see some fluid over here. So the first thing that should come in your mind is the inflammatory condition. So it may be a hematoma. There might be a history of trauma, 60 years old female patient. So there should be some history of trauma, but there is no history of trauma. Patient was asked this question several times, so she was not happy to see the same question repeatedly. So anyway, you see, I'm putting some compression and there is some movement of internal particles here. So yeah, it might be an inflammatory condition. That's good. So let's see that part again and again. So I'm moving the transducer. If it was a 6-year-old boy or 6-year-old woman, whatever you say, I won't make the same diagnosis like an inflammatory state. So I should think about some other differentials. So this thing looks like an inflammatory condition or some multi-septate collection, but I'm not very much satisfied with that diagnosis for this case also. Because the internal particles are slightly just moving with some compressions or even without some compression. You see some hazy content inside. Okay, so these are multiseptate, but this doesn't look like the septations only. So what it can be? Let's see on another view. So this is the lesion hole length of lesion. So it measures around 5 centimeter in length. Okay, that's good. So it's located over the patella. You see, this is the patellar tendon over here. So it's just below the skin and subcutaneous tissue. So it's very superficial. There is no connection with the bone. It's just separated by the musculofascial layer. Okay, so here's the panoramic shot. You can see the whole length of the lesion. This is the patellar tendon over here going downwards. And yeah, okay. Now, what further I can do to make a diagnosis? Obviously, I want to use the Doppler. So I have many questions inside my head now, and I want to solve all of them using the Doppler. So let's put some Doppler. So I'm not compressing, I'm just putting the Doppler. So when I put the Doppler, I can see there is a low PRF setting. So there should be some vascularities at surrounding region. Okay. You can see there is no prominent vascularity inside, some artifacts and whatever we'll see on real time. Yeah, I'm not very much satisfied with the Doppler now. Okay, it looks like an inflammatory condition, but whenever I see some cystic spaces containing some fluids and something like that that moves, or moves with pressure, I want to use some compression over this area. So when I try to compress and remove the compression, just I put the transducer compression and relieved it, the picture came like this. So, now I have changed my diagnosis. This is not an inflammatory condition. In case of inflammatory condition, these cystic spaces won't fill with this amount of blood. So this is nothing but a venous malformation. I don't know how this patient got this atypical thing at 60 years of age. But yeah, this is a venous malformation. Let's see on real time. Now I'm using the power Doppler. I am very happy. So I want to enjoy compressing over this malformation. And now you can see it's just getting filled with the blood. So this is nothing but a venous malformation over the patella. Okay, so this is quite unusual to have a venous malformation at this age, at this location. So this is a vascular malformation over the left patella, possibly a venous malformation. Okay, so let's jump into the case number 4. So this is a 68-year-old male patient, and he came with lower urinary tract symptoms and hematuria. Okay, so there was raised serum creatinine, so the patient is a chronic kidney disease patient. Let's see what we have got on real time. So this hematuria, I'm not concerned about the lower urinary tract symptoms. I may get some prostatic enlargement or something like that, 68 years old male. But the hematuria took our attention because it should not be present there. So let's see what we have got on ultrasound. Now you can see this is the urinary bladder. It's not well filled, but it's okay. It's good to say that there is no lesion inside because I checked it on real time. So I measured the prostate. I don't know why I am very poor at measuring the prostate volume. So it's my limitation, I think. So anyway, the prostate is slightly enlarged. Okay, let's jump into the kidney. So this is the right kidney. It's completely echogenic. You can see there is loss of corticomedullary differentiation. You can't differentiate the cortex and medulla. The pyramids are completely lost almost. If you compare the echogenicity with the liver, it's more echogenic than the liver parenchyma. You can see at the end, at the upper pole, there is a cystic lesion, that is the cortical cyst, which is benign finding. But you are not looking at that part. I think you are looking at this one. So this notorious structure is not a good thing. It's a mass lesion. You can see at the lower pole. It's a solid lesion, and the echogenicity is almost similar to the parenchyma. So you can say it isoechoic or hyperechoic, whatever. So this is a solid lesion. Let me freeze the image a little bit. So you see some anechoic area inside. It might be the necrotic part. It might be the blood vessel. I don't know. I need to put Doppler. So this thing is getting originated from the lower polar parenchyma. Okay, there is no vascular invasion in such case, I think, because the lower polar one doesn't disturb the renal vessel or main renal artery quite. But if it was located at the mid part, the situation would not be the same. Okay, anyway, we need to check the inferior vena cava. In this case, I checked the inferior vena cava is quite good. So anyway, many things are coming. So let's see on another view. You can see the poor kidney and the upper polar cyst, and you can see this lesion at the lower pole, which is suspected as the renal cell carcinoma. This is a very common appearance of the renal cell carcinoma, and this is the reason for the hematuria in this patient. Okay, so not a good finding. So the kidney is quite normal in size. In my country, we follow the 8 centimeter length as a normal one. This kidney is actually small, but due to the mass at the lower pole, it looks quite normal in size, in length actually, but it is still a small one because yes, if you cut the mass, the kidney will get 6 centimeter or below that. So anyway, let's put some Doppler. So on Doppler, you can see there is a good amount of vascularity. You can see a prominent peripheral vascularity, and you can see some penetrating vessels inside, going inside. So if you follow the Zinzaki classification of the renal mass vascularity, which is the sonographic vascularity criteria, so then it is at the Zinzaki score or class of 4. In this classification, we go for if there is a large peripheral vessel and penetrating central vessels present, we go for the class 4. So you can just search the Zinzaki classification. You can get that. Okay, it's not important to write down the type 4 vascularity, so clinician will get confused. Rather, you can just describe it. Okay, so anyway, this is a highly vascular mass, and in case of kidney, if you see a mass with high vascularity, you go for the renal cell carcinoma first. But we'll go with other investigations, obviously. So anyway, the central part where we saw a cystic area, there is no prominent vessel over there. So that was a necrotic area, which is also can be seen from this part. You see this part is quite dark here. These are some necrotic portions, which is also common in renal cell carcinoma. Okay, so yeah, this one. So it's just nearby to a blood vessel here. And you can see the mass is around 4 centimeter, and it's quite a round mass with a good amount of vascularity, which is not a good finding for us. So the left kidney was also small and very much echogenic, and yeah, there is loss of corticomedullary differentiation. So very poor patient. So this was a case of right renal lower polar highly vascular solid mass, so which needs further evaluation to exclude the renal cell carcinoma. So the patient will go for this contrast CT first, I think, or clinician may choose the biopsy. So it depends on the clinician. So we don't actually deal with that. So there was bilateral chronic nephropathy with right renal cortical cyst, and there was enlarged prostate also. So very poor case. Let's jump into the case number 5, to this last case. And this will be obviously a pregnancy case. So I have got many congenital anomaly cases in last month. So to share them one per week, it will take a very long time to end. Okay, anyway, let's jump into this case. This is a 20-year-old female patient who came with amenorrhea for 5 months. So she came for a congenital anomaly scan. There was no previous scan after 8 weeks of gestation. So she just checked whether the baby is alive or dead at 8 weeks. Now came for anomaly scan. Now I was a little bit confused because this patient should have at least a single scan in between this long journey. So anyway, let's see what we have got on ultrasound. So here, oh, you already can see the lesion. So anyway, here we have measured the biparietal diameter of around 22 weeks. Okay, the femoral length says it's around 20 weeks, so the difference is quite bigger. And so head circumference is around 22 weeks. So BPD and the head circumference is quite similar. Abdominal circumference is saying that it's around 37 weeks of gestation. And what is this? What is this? And what is this? So something abnormality is going on in the abdomen. But there's something else also. So let's see what we have got on this ultrasound. Now here you can see the lung section. So we have multiple findings. What you are looking at is the ascites. This is not the pleural effusion. This is the ascites. The problem is in the lung. So you see these are the lungs. These are very big lungs. And this one is the diaphragm. You see diaphragm should have the convexity upwards, but here you can see it is having convexity downwards, which is called the everted diaphragm. So definitely the lung is pressing the diaphragm to get everted, which is not a common finding. And which lung is enlarged? You can see all 2 lungs are enlarged. And where is the heart actually in this patient? The heart is located at the central part, not at the left or right. It's located at the central part. And yeah, it's pumping good, but it's not in a good situation because it's a little bit compressed. You can see it's a small in size. So there are lots of different findings here. You can see a huge ascites over there. Okay, so surrounding, if you see the surrounding fluid, I can see the amniotic fluid doesn't look quite normal. It is already having some oligohydramnios. So the condition is not very good. So if you see my face during the scan, you'll say that something abnormality is going on. And in this situation, the patient asked me about the gender of the patient, baby. She even didn't ask for the condition, whether it's good or bad. And in my chamber, it's completely banned to say the gender, so I just ignore it. She repeatedly said that this is my first baby. I want to enjoy that. I want to buy that and that, whatever. So I'm just say that I say that just wait, let me finish the scan and then brief you. Okay, so yeah, you can see right now. Just let me change the slide. Okay, yeah. So I have used the color Doppler here and put the Doppler over this part. You can see the heart is pumping quite good. And you can see prominent vessels over here. These are the pulmonary arteries. And okay, so pulmonary vessels are pumping quite good. They're very prominent, and you can see the lungs are quite very enlarged. Okay, so whenever you see two lungs are enlarged, they are echogenic and they're compressing the heart at the central part, it indicates that there is a obstruction at the very high level. If you just block a bronchus, the later part will be enlarged and echogenic in fetus. So if you can block the principal bronchus of right lung, the right lung will get enlarged and echogenic. If you obstruct the laryngeal level, larynx or trachea, then all two lungs will get enlarged and echogenic. What happened in this case? So this is a high obstruction. Okay, so let's see it again. Now you can see this is a big chunk of lungs, and the heart is compressed, centrally placed, and narrow a little bit. I checked whether there is any abnormality within the heart. The heart is only compressed. There is no VSD or any other abnormality present. So this is the condition. This is not a good condition. The prognosis, if you ask me, if you don't have the larynx quite well after delivery, how will you breathe actually? So you won't get much time. So the prognosis is not very good, especially when you are seeing a good amount of ascites in such case. Now, what else you want to see in this case? You are making a big diagnosis, but you need to diagnose a little more, because in this situation, you just think that this is a very big lung. So they will compress the heart. So here is the area for the esophagus. So if it can compress heart like this, esophagus won't be able to get a very good space to move the fluid. So it will also get compressed. And how can you check that? Just check the stomach. If the stomach is present, then esophagus is okay. Okay, so we'll check that. If the esophagus is compressed, then obviously there should be polyhydramnios. This patient is having oligohydramnios. So if there is oligohydramnios, then you should check the kidneys also, because if there is any abnormality in lung, you should search for the kidney. If there is any abnormality in kidneys, you should search for the lung, vice versa thing. So we'll check that also. So let's look at the long section. Now you can see the liver, you can see the kidneys over there. These are the kidneys, but you can't see any view of the stomach here, which is an important finding. Okay, so let's see the kidneys. But before that, you can see this echogenic lung compressing the heart at the central part. These are the kidneys. You see, I can't say them as echogenic because you can compare the echogenicity with the adjacent liver or lung. So no matter how you compare, the renal echogenicity is not very bad. So the kidneys look quite normal. Now, if you look at the urinary bladder, we searched for the urinary bladder. It was empty. I took more than 30 minutes to scan this patient, and I have never seen a filled urinary bladder in this case. I search for any gap within the urinary bladder, so I can just say that there was a urinary bladder obstruction, bladder got ruptured, so the fluid from the bladder came into the abdomen, forming the ascites, but there was no option for that. Again, if there was a bladder obstruction, the kidneys should not look this good. So there should be something abnormality in these kidneys. So we put Doppler and you can see the iliac vessels, internal iliac vessels just beside the urinary bladder, which are the points to search for the urinary bladder in empty state. So I can see the urinary bladder is almost empty. So the situation is that the kidney is not producing the urine or something like that. So that's why there is a very poor amniotic fluid. Now we search for the stomach, but there was no stomach present in this case, or filled stomach present in such case. So we can say that the lungs are causing obstruction or compression over the esophagus, or as there is a abnormality in the larynx or tracheal level, esophagus may also get involved. So there might be an issue obstruction with the esophagus also. We don't know. We need to search for that. If you want to go further, you can do a fetal MRI. So anyway, we checked the spine. We expected some spinal abnormality, but it looked quite normal. So you can see we put some 3D on a skeleton mode, and now you can see the whole of the spine. You can see the sacrum and part of femur also. Okay, we check the cardiac activities because when you compress the heart may not have some structural abnormalities, but there should be some functional abnormalities also. So we checked all the valves, but in our scan, we found something abnormal here. Like when we were checking the heart, it was like 151 beats per minute, which is quite normal. We are very happy with that. But after a few minutes, I saw that the heart doesn't look quite normal during pulse. So I checked the pulse rate. So the heartbeat became 51 beats per minute, which is not very good. So the heart pumped like very slowly. So like you see, now it's pumping. So it's the last stage of bradycardia. So when it was very slow, I was just trying to check the pulse wave Doppler to see the heart rate. But when I came back to the real time, it just got resolved. So now it's pumping good. So at the beginning, it was a little bit slower. So anyway, it indicates that the fetus is already getting some bradycardia or bradyarrhythmia or cardiac arrhythmia because you are compressing the heart. So the situation is getting worsens. No, we are not very satisfied with the situation. So anyway, so this is the 3D image of the lung, liver, intestine. This is a glimpse of kidney in 3D. And this is the huge ascites. So whenever you get a fluid, you just practice 3D. That is the principle of learning 3D easily. Okay, so this is a big report, so I will summarize it a little bit later. So we just try to make some description, ignore the mistakes here because this is the just format. So we just reported many things. We couldn't see the trachea up to the bifurcation level. We tried to trace it. So you can see the trachea on the 3-vessel view of the heart. So we tried to scan it, but we couldn't find it. So and that was our limitation. And the diaphragm is concave upwards, or you can say it is everted. That is the easiest word. So fetal heart is the middle and it is compressed. We saw the significant bradycardia of 51 beats with a regular rhythm indicating the early appearance of cardiac arrhythmia. There was no other abnormality found. The abdomen is distended. Gross ascites, we couldn't find any stomach here. The kidneys look quite normal, but the urinary bladder remained empty during the scan. So we say that our weight came from our machine is not inaccurate because of the distended abdomen. So we need to inform that to our clinician. And definitely the machine given expected date of delivery or 40 weeks date is not accurate here. In our country, we still have to give the EDT at the latest stage also, but in some countries they only give it only during the CRL measurement. So, but our patients come to us even the first visit they make at 40 or 42 weeks. So we need to give something to our clinician. So that's why it's still practiced in our country. So it may differ from country to country. And yeah, we said many things. So just summary it here. So this was a 22 plus weeks of single live intuitant pregnancy with mild oligohydramnios. And the features you have seen, the large bilateral enlarged echogenic lungs is due to the high obstruction. We call it the congenital high airway obstruction syndrome. It has different synonyms. That is called the chaos or chaos, whatever you say. So it is a chaotic situation, obviously. So it's causing the bilateral distended lungs and compressed heart, which is also responsible for the cardiac arrhythmia, obviously. There was gross ascites, and we couldn't see the stomach, so we recommended to see that on follow-up scans. Same for the urinary bladder. And yeah, so we are suspecting that the kidneys are not producing any urine in this situation. There are so many reasons for that it can happen. So we need to evaluate it also in follow-up scan. So I don't know who will give this patient the follow-up, but if you are watching this thing, then make sure you have many things to do in this patient. So yeah, it's one of the best 30 minutes of your life if you practice ultrasound, but it's the worst time for a patient because she is facing the worst time of her life. So anyway, thank you for joining us today. Our next session, the next Friday is the Eid day for many parts of the world. So we say Eid Mubarak to all. For our country, the Eid day is on the 7th June. It will be celebrated. So so we will try to arrange a session on 13th June, the week after the Eid holiday. And yeah, it will be on 9 p.m. On 13 June. We'll try to continue it regularly. So if you're from my local country, we have a session, not free session, it's a paid session on basics of the color Doppler ultrasound on tomorrow at 8:30, not the 9 p.m. Be careful about that. It's 8:30 at the night. And if you haven't joined there, so you can just register for this program. And if you're from any part of the world, you are getting angry because we are not arranging this type of session for you. I'm very sorry for that because this is on my local language, not in English. And again, we have said it before that uh, you can pay for this session, but we can't refund you. So refund policy is very difficult from my country to other country. We can take money from you, but we can't send it back. So if when we will be able to refund you, then we can arrange you this type of session for you, even in English or something like that. So hope to do it very soon, but I don't know when it will be possible. Okay, so sorry for that. So if you're new to our program, so we have a YouTube channel named Imaging Study, and you can just join us there, subscribe to our YouTube channel, and get many free contents over there. So we have uploaded many cases recently, so you just can go our and check our previous sessions. Hopefully, these sessions will be helpful for many of you. Okay, so we have a website, which is a boring website because it's not getting monetized. I don't know why. So I'm feeling bored to work with that. Anyway, our paid sessions, the notice of paid sessions are given in uploaded in this website. So you can just go and get the latest information about our next sessions. So thank you for joining us today. So if you have any question, you can just put the question on the chat box because I'm just watching the live session also from my phone just beside me. So yeah, Eid Mubarak. Alaikum Assalam. Yeah, I'm fine. So many people are watching from far away, from like from a 12-hour time duration distance. Okay, so it's a very big time duration distance. So we'll upload this session. If you have missed the first part or any part, so we'll upload this session tomorrow in our YouTube channel. So you can just go and see the any part you want from our YouTube channel. Okay. Okay, so we can finish now. So thank you for joining us today. Hope to see you on our next session on the 13th June. So have a good holiday. Enjoy your time. See you on the next one. Have a nice day.